Now, VRG matters more than ever. Definition: when we define the postmenopausal bleeding, PMB, bleeding presumed to be form of uterus occurring 12 or more months after the final menstrual period. Any bleeding meeting the definition warrants a clinical evaluation regardless of amount, duration, or whether it recurs. Now, the differential diagnosis, the common causes of PMD are: benign ones are the endometrial or vaginal atrophy, most common cause, endometrial polyps, endometrial hyperplasia without atypia, and fibroids. Malignant or the pre-malignant is endometrial carcinoma, atypical hyperplasia, cervical carcinoma. The scale of the problem is PMB and endometrial cancer risk. It's more than 90% of women diagnosed with endometrial cancer report postmenopausal bleeding. And almost 9% of the women with postmenopausal bleeding are ultimately diagnosed as endometrial cancer. So, the background is the old Paradise Committee Opinion 734. It suggests previously that transvaginal ultrasound alone was considered sufficient for initial evaluation in patients with PMB and endometrial thickness, that is ET, is more than 4 mm. But no biopsy was required in that low risk group. But now things are changing. In 2026 update, ACOG now recommends combine the transvaginal ultrasound and endometrial tissue sampling as a part of initial evaluation in most patients with PMD. The comparison old versus new at a glance, initial evaluation in a previous guidance, transvaginal ultrasound alone acceptable if ET is less than 4 mm. And biopsy requirement is no need of in low risk thin ET group. But now update of 2026 is transvaginal ultrasound plus endometrial biopsy recommended for most patients, recommended regardless of ET. So rationale is why the change, and what is the rationale is earlier more comprehensive screening, combining modalities supports catching disease sooner rather than waiting on ultrasound finding alone. The prompt diagnosis is prioritized. Sampling in the initial visit always delays the introduced by stage ultrasound first approach. Now, the reduced risk of a missed cancer is biopsy at first presentation, lowers the chance of the malignant and pre-malignant pathology goes undetected. So, the core problem is low sensitivity. Using endometrial thickness alone as a triage tool is associated with unacceptably low sensitivity for malignant and pre-malignant endometrial pathology. Thus, the health quality data suggests even a reassuring ultrasound can miss the cancer. In 11.4%, patients with endometrial cancer had ET below the standard triage threshold, and the classic risk factors PMDR, age, BMI did not improve the diagnostic threshold performance in this population. So the diagnostic limitation, aggressive cancers don't look abnormal. Some aggressive endometrial cancers are not associated with the demonstrable ultrasound abnormalities. This is the key reason ultrasound alone is insufficient for triage. The misdiagnosis, 5 to 12% of patients of endometrial cancers may not be diagnosed on initial presentation when clinicians rely on ultrasound alone. So the risk stratification, the risk factors are, and that raise the suspicion, 7.5 or age more than 55, odd ratio versus younger patient. 4.9 or a recurrent bleeding more than 2 episodes, it's an odd ratio. Same 3.1 or diabetes or hypertension, these are the odd ratios also. So what should be the clinical pathway? The new recommendation initial and evaluation pathway suggests first and foremost thing which we should do, the history and the pelvic examination. Then transvaginal ultrasound and endometrial tissue sampling performed together at initial visit. And third point is pathology results guide the next steps. So reassurance, surveillance and oncology referral comes all together. So endometrial thickness still useful, not just sufficient alone. ET cutoff study, 3 mm sensitivity high, but specificity for the endometrial cancer is low. 4 millimeter, again sensitivity is high, but specificity low. And same with 5 millimeter, the sensitivity is high, but the specificity for the endometrial cancer is again low. But 0.7% residual cancer risk with ET is less than 5 mm, but it is not zero. So all studies cut off 3, 4 and 5 mm proved highly sensitive but not specific for the endometrial cancer. So technique options, sampling technique options, office endometrial biopsy we can take, quick first line approach for most patients. Office hysteroscopy, guided sampling, direct visualization, better for local lesions. Dilatation and curettage, reserved for inadequate office sampling and inclusive results. So the patient communication is a shared decision making. The decision is proceed with endometrial sampling should result from shared decision making and reflect the patient's values and preferences, not a default without discussion. So emerging evidence, patient-centered counseling improves update. Early data suggests patients are more likely to undergo endometrial sampling at their initial evaluation when the clinicians use patient-centered counseling and shared educational materials. So the HRT users, endometrial thickness cutoff interpretation differs from the patients on the hormone replacement therapy. But clinicians should not apply the standard non-HRT threshold directly. And if there is a special population, recurrent PMB should be investigated regardless of ET, hysteroscopy and often needed. There is a 17.5 4-year standardized incidence ratio for the EC in the patients with PMB if it is more than 4 mm and hyperplasia without epitopia on initial biopsy. So the access and equity benefits of the combined approach, performing ultrasound and biopsy together at one visit, can reduce the healthcare burden for the patient, limited access to prompt gynecologic, radiologic and oncologic care, fewer written visits and faster answers. So this is a vignettes applying the pathway. 58-year-old single episode of spotting, ET is 3 mm on transvaginal ultrasound. Old guidance, reassure no biopsy. But new 2026 guidance offer combined biopsy at same visit with shared decision making. Same with another case, 62-year-old recurrent bleeding, ET is 4, diabetes plus hypertension, elevated risk profile, age, recurrence, commodities, all point toward the proceeding with the biopsy. If hyperplasia without ATPI is found, case follow-up guaranteed for long-term cancer risk. So the practice points are common pitfalls to avoid. Don't reassure solely on thin ET. Don't skip biopsy on high-risk patients on the ultrasound alone. Don't treat recurrent PMP as just atrophy without reinvestigating. And don't skip the counseling conversation before recommending and sampling. So the key takeaways, clinical checklist is PMB is equal to bleeding more than 12 months after menopause. Transvaginal ultrasound plus biopsy together, not TVOS alone for most patients. ET alone has unacceptably low sensitivity. Shared decision making guides the conversation and extra vigilance for the patients in the recurrent bleeders. So thank you so much for today's Grand Round Live. I'll be there regularly for this Grand Round Live. Please subscribe and like the channel so that you will come to know the next topic we are going to talk about. Thank you so much.